as well as we should able to classify arrhythmias, and then we will be coming to the classification of antiarrhythmic drugs, and what are the important things that you should know about the antiarrhythmic drugs. We should know the pharmacokinetics, you should know about the mechanism of action, therapeutic uses, and adverse effect of different antiarrhythmic drugs. So inshallah, one by one, we will be completing our all of these objectives. And inshallah, I will be uploading this PowerPoint presentation on Edmodo also, as well as there will be a little quiz regarding this topic. So we kindly attempt that quiz also. So starting with the definition of arrhythmia. What is arrhythmia? It is a deviation of heart from normal rhythm. So you should know about the normal rhythm, the characteristic features of normal rhythm. What is the characteristic features of normal rhythm? The normal rhythm should be in between 60 to 100. The heart rate of the normal rhythm should be between 60 to 100 beats per minute, and it should be originated from SA mode, as well as the cardiac impulse should propagate through normal conduction pathway with normal velocity. So these are the normal characteristic feature of the normal rhythm. So whenever there is a arrhythmia, there will be some deviation of heart from normal rhythm, and all of these parameters will be changed. So if we talk about the classification of arrhythmias, as you all know that normal heart rate is in between 60 to 100, but if we talk about tachyarrhythmias, the heart, if the heart rate will be above 100, like if it will be above around 150, then we will be labeling that term as simple tachyarrhythmia. And if the heart rate is about 200 heartbeats per minute, we will be labeling this as paroxysmal tachyarrhythmias. And if the heart rate is around 350 beats per minute, we will be labeling this disease as atrial flutter. And if the heart rate is around 500, we will be labeling this as atrial fibrillation. In contrast, if the heart rate is below 60 and it is around 40 beats per minute, we will be labeling it as mild bradyarrhythmias. And if it is around 20, then we will be labeling as moderate bradyarrhythmia. And if the heart rate is below 20, then we will be labeling it as severe bradyarrhythmia. So you can see in this picture that there are different types of arrhythmias, and if the arrhythmia is arising from sinus node, then we will be labeling it as sinus arrhythmia, as well as if the arrhythmia is arising from any region of atrium, then we will be labeling that arrhythmia as atrial arrhythmia. And if the arrhythmia is arising from AV node, then we will be labeling this type of arrhythmia as nodal arrhythmia. And any type of arrhythmia that will be arising from ventricles, we will be labeling that arrhythmia as ventricular arrhythmia. So what is SVT? It is supraventricular tachyarrhythmias, and it is clearly shown in this picture that if the arrhythmia is arising above the level of ventricles, then we can term that arrhythmia as supraventricular tachyarrhythmia. And supraventricular tachyarrhythmias will be sinus arrhythmia, atrial arrhythmia, or you can say nodal arrhythmias. These all type of arrhythmias, we can classify all these types of arrhythmias in supraventricular tachyarrhythmias. So you should know about the impulse generation and transmission, that how the impulse is generated from SA node, and then it is coming to AV node, and from AV node it is propagating through the right bundle branch as well as through left bundle branch to different areas of ventricles. So if we talk about cardiac action potential, it is divided into 5 phases. it is phase 0, which is rapid depolarization. Phase 1, in which early depolarization is occurring. In phase 2, there is a plateau phase. In phase 3, there is rapid depolarization. And phase 4 is resting phase or diastolic depolarization. So, when we'll be discussing about antiarrhythmic drugs, then it will be clear to you all that all the antiarrhythmic drugs will be affecting any of these phases. Like some antiarrhythmic drugs will be affecting on phase 0, some drugs will be affecting some another phase. So if we talk about the different phases, if we talk about phase 0, there will be a rapid depolarization of cell membrane, during which there is a fast entry of sodium ions. If we talk about phase 1, it is a short initial rapid depolarization due to potassium reflux. And in phase 2, there is prolonged plateau phase due to slow calcium influx. In contrast, in phase 3, there is a rapid depolarization with potassium influx. And in phase 4, there will be a resting phase during which potassium ions will be returning into the cell, while sodium and potassium will be moving out of it. So now we'll be coming to anti-arrhythmic drugs. And regarding anti-arrhythmic drugs, firstly, you should know the classification of anti-arrhythmic drugs, that how can you classify anti-arrhythmic drugs. So there is a classification given by Vaughan Williamson in 1969, and through this we can classify the anti-arrhythmic drugs. And this classification is based on the mechanism of action of different drugs. Like all of the drugs that will be included in class 1, all those drugs that will be included in class 1 will be having the same mechanism of action, that these drugs will be blocking sodium channels. In contrast, all of the drugs that are included in class 2, all those drugs will be all those drugs are the beta blockers, like atenolol, sotalol. These both drugs are beta blockers. If we talk about class 3 group, the drugs that are included in class 3 group, these are the potassium channel blockers. And if we talk about the class 4 drugs, they will be the calcium channel blockers. So different groups have different mechanism of action. If we talk about class 1, they are the sodium channel blockers. Class 2 are the beta blockers. Class 3 are potassium channel blockers. And class 4 are calcium channel blockers. Okay, so you can see in this picture that the drugs of class 1 are affecting some another phase. Class 2 drugs are affecting some another phase, like phase 4. Class 3 drugs are increasing the prolonging the action potential as well as the refractory period. If we talk about class 4 drugs, it will be affecting mainly the phase 2 of the action potential. So you should know the mechanism of action of all of the anti-arrhythmic drugs, that how the anti-arrhythmic effects are produced by different drugs in the body. So again, we are discussing that class 1 drugs are sodium channel blockers, and they will be affecting the slope of phase 0. If you talk about phase 2, they are the beta blockers, and they will be decreasing the heart rate and conduction velocity. If you talk about class 3 drugs, they are the potassium channel blockers, and they will be increasing the action potential duration as well as the effective refractory period, as well as these drugs will be delaying the repolarization. Then if you talk about class 4 drugs, these drugs are calcium channel blockers, and these drugs will be slowing the rate of rise in phase 4 of SA mode, as we have discussed in this picture, that class 4 drugs are affecting the phase 4 of the action potential. Then one by one we'll be discussing each classes. We'll be beginning from class 1 anti-arrhythmic drugs, which are the sodium channel blockers. and they will be binding to the sodium channels and will be blocking sodium channels, as well as these drugs will also be blocking the potassium channels also. So they will be acting on the initial rapid depolarization phase. And as these drugs will be blocking the nerve conduction in higher concentration, so these drugs can also be used as local anesthetic drug. So they are class 1 drugs are further divided into class 1A, class 1B, and class 1C. And we can differentiate these classes on the basis of efficacy of these drugs. Like the class of drugs that are included in class 1 A are moderate sodium channel produce moderate sodium channel blockage. If we talk about class 1B, the drugs that are included in class 1B will be producing mild sodium channel blockage, and the drugs that are included in class 1C will be having a marked sodium channel blockage effect. If we talk about the mechanism of action of these three subclasses, class 1A drugs will be prolonging the refraction by blocking several types of potassium channel. In contrast, class 1B group will be having little effect on refraction, as there is minimal effect on potassium channels. In contrast, class 1C drugs will be prolonging the refraction by blocking delayed rectifier potassium channels. What is the refractory period? It is the period during it is the rest period in between the two action potential duration. So different antiarrhythmic drugs act by prolonging the refraction period, as well as different antiarrhythmic drugs will be having their mechanism of action of increasing the duration of action potential duration. Okay, so as you see in this picture, that class 1A drugs will be lengthening action potential duration, prolonging the repolarization. Class 1B drugs will be shortening the action potential duration and repolarization, while the class 1C drugs will be having no effect on action potential duration and repolarization. So if we talk about class 1A drugs, it will be slowing the phase 0 depolarization, as well as prolonging the action potential, and will be slowing the conduction. And by this mechanism of action, these drugs will be producing the antiarrhythmic effect. As well as quinidine, procainamide, and disopyramide will be blocking the open or inactivated sodium. So if we talk about quinidine, if we talk about the pharmacological effects of quinidine, it will be increasing the threshold for excitability, as well as it will be decreasing the automaticity, and it will be prolonging the action potential. And if we talk about quinidine, it is the first antiarrhythmic drug that was used, and it was derived from the bark of the cinchona plant, as well as it was used to treat palpitations also. So if we talk about the clinical pharmacokinetic of this drug, it is well absorbed. 80% of percentage of this drug is bound to plasma proteins, and it is extensive hepatic oxidative metabolism will be occurring of this drug, and its metabolite, which is 3-hydroxyquinidine, is nearly as potent as quinidine, blocking the cardiac sodium channels and prolonging the cardiac action potential. If we talk about uses of quinidine, it is used to maintain the sinus rhythm in patients with atrial flutter or atrial fibrillation, as well as quinidine is used to prevent recurrence of ventricular tachycardia, or you can say ventricular fibrillation. If we talk about the adverse effects of quinidine, we will be classifying, or we can say we will be dividing the adverse effects on the basis of cardiac adverse effects and non-cardiac adverse effect. If we talk about the non-cardiac adverse effects, it will be including the diarrhea, thrombocytopenia, kinconism, and skin rashes. What is kinconism? It will be including a series of symptoms that will be including the like blurry vision, hearing loss, tinnitus, dizziness, as well as flushing. So this series of symptoms is labeled as kinconism, which is one of the major adverse effect of quinine, as well as related to some cardiac adverse effect. Quinine will be producing marked QT interval prolongation as well as torsades de pointes. What is torsades de pointes? It is the type of ventricular tachyarrhythmias in which there is some QRS complex is being affected, and there is a little bit twisting of QRS complex, as well as the amplitude of QRS complex is being altered. So some of the drugs that are included in 1A group like quinine will be producing torsades de pointes also. Apart from torsades de pointes, there will be marked QT interval prolongation also, but it is a rare side effect. Apart from this, there will be hypotension and tachycardia also. If we talk about drug interaction, quinine is being metabolized by CYP450, and it will be increasing the digoxin levels if the digoxin is being taken along with quinine. There will be the cardiac depression with beta blockers, and quinine will be inhibiting CYP2D6 hepatic enzyme. If we talk about disopyramide, it will be exerting the electrophysiological effect that is very much similar to those of quinine that we have just discussed. It is better tolerated than quinine, and it exerts prominent anticholinergic actions as well as negative inotropic action. So due to this prominent anticholinergic actions, the adverse effect of these drugs are also anticholinergic related, like there will be some constipation, dry mouth, urinary retention, as well as precipitation of glaucoma. Then if we talk about procainamide, this drug is metabolized by acetylation to N-acetyl procainamide, which can block potassium channels. It does not alter plasma digoxin levels, and cardiac adverse effects like quinine are present. It can cause SLE, so it is not recommended to use these drugs continuously for more than 6 months. As well as if we talk about the clinical use of procainamide, it is used in atrial and ventricular arrhythmias. In last, we will also be discussing the drugs of choice in different types of arrhythmias. So you should know about the drugs of choice that we are using in different types of arrhythmias. If we talk about class 1B group, this group includes lignocaine, phenytoin, and maxilidine, and it will be blocking the sodium channel as well as it will be shortening the repolarization. So class 1B drugs will be shortening the phase 3 repolarization, and it will be decreasing the duration of action potential. If we talk about lignocaine, in addition to sodium channel blockage, it also shortens the phase 3 repolarization and decrease the duration of the action potential. So by decreasing the duration of action potential, it will be producing its antiarrhythmic effect. It is useful in ventricular arrhythmias, digitalis induced ventricular arrhythmias. If we talk about the adverse effect profile of lignocaine, it is relatively safe in recommended doses. Drowsiness, disorientation, muscle twitching, rarely convulsions, blurred vision, nystagmus, which is defined as repetitive eye movement, as well as there is some least cardiotoxic antiarrhythmic effects, but they are very much less. So this drug is relatively very much safe if you talk about lignocaine. And if we talk about the different properties of lignocaine, we can easily remember the properties of lignocaine by this mnemonic, that is lignocaine Like from L, you can remember that lignocaine is a local anesthetic drug. It is inactive orally. It is given IV for producing the antiarrhythmic action. Sodium channel blockage, which will be occurring, is only inactive state of sodium channels. CNS side effects will be producing in high doses. If we talk about duration of action, the duration of action will be lasting only for 15 minutes. It will be inhibiting Purkinje fibers and ventricles, but there will be no action on AV node and SA node. So it is only effective in ventricular arrhythmia. So please do remember that if we talk about lignocaine, it will be only be affecting and it is only therapeutically useful in ventricular arrhythmias only. Now we'll be talking about Maxility, which is the oral analog of lignocaine, and there will be no past metabolism in liver. If we talk about the uses, it will be used in chronic treatment of ventricular arrhythmias associated with some previous myocardial infarction, as well as unlabeled use in diabetic neuropathy also. Tremor is early sign of anxiety, toxicity, and hypotension, bradycardia, widening QRS complex, and dizziness as well as nystagmus are some of the adverse effects. If we talk about procainamide, it is structurally similar to lignocaine but can be administered orally. So this is the differentiating factor between lignocaine and procainamide, that it can be administered orally. Serious non-cardiac side effects like pulmonary fibrosis, granulocytosis, thrombocytopenia will be limiting its use. Then in last, we will be discussing about the class 1C drugs, which include antiarrhythmic, flecainamide, and propafenone. And these drugs will be markedly slow the phase 0 depolarization, as well as these drugs will be having the minimal effect on repolarization. Among all of the class 1 drugs, these are the one of the most potent sodium channel blockers, but risk of cardiac arrest and sudden death are very much high, so it is not used commonly, but it may be used in severe ventricular arrhythmias. Then if we talk about propafenone, it is a structural similarity with propranolol and has beta blocking actions. It undergoes variable first pass metabolism. It is the reserved drug for ventricular arrhythmia, re-entering tachycardia involving accessory pathway. If we talk about adverse effects, metallic taste, constipation, and it is pro-arrhythmic. Then if we talk about flecainamide, it is the potent blocker of sodium and potassium channels. It will be blocking potassium channel, but it will not be prolonging the action potential duration in QT interval. And it will be maintaining the sinus rhythm in supraventricular